both Bren and Albert, really good to see you. We're going to go firstly to declarations of interest. Can I just check if anybody's got any other declarations for the meeting that aren't already in the declarations of interest that are circulated? No? Great. Can we go on to the minutes of the last meeting held on the 28th of November, please? Has anybody got any queries, comments, or changes they want to make to those minutes? No, can we sign them as approved? Yeah, brilliant. Thank you very much. We go on to the action log. I just need to scan through. Will I find the right section of the minutes? Is it always a pain when you've got when it's on a laptop? But it saves lots of paper. That's the right thing to do. I chaired a charity board meeting yesterday and they gave me all the papers. I had so many bits of paper, it's unbelievable. But it was easier. Okay, so the action log, we've got, so Anne, there was one on reporting on the One Plan for children and young people. That the date of that we've got is March. Is that still potential? Is that still appropriate for you to report back on that?
So
can you use your mic?
I will check when my computer starts working. I know I needed to push it off with Mark because there was one accident made, and I don't know whether what's arrived in the papers gives you a new date or not.
Yeah, what it says is we need to check whether it can go onto the March agenda. So I think onto the March agenda. The next one is recommended to be closed. Mark, you have done the work on that, so happy we could be recommending closure of that. And then we've got a couple from our development session. Again, one to be closed, which was Siobhan's, because that's planned for a development session, and then there was a further EPPR to be placed on future board development. My expectation is if we do that, we may well need to do that as a joint one as a cluster. So that will be carried forward, I would suggest, for the cluster board to look at. Is everybody happy with those? Yeah. Okay, perfect. Thank you. We do not have any questions from members of the public, so that means we move straight into what we've used this as our patient story, which is feedback that has been led on with the public on public engagement and the NOW programme. So I'm going to hand over to Becky. Thank you.
that number. It's exactly 429. Good mix. Good mix of demographics. Quite a disproportionate response from people from the Botswana district, and I'll come on to that in a minute. There was not a lot of difference in the responses between our general population survey and our People's Panel survey. And most of you will be familiar with the People's Panel, but just for those who are not, People's Panel is recruited from people who live in the county to make sure that we have a good representative sample of age, gender, ethnicity, care responsibilities, etc. They are kind of a good sort of group to get a representative response. The rest of them are public who are interested and want to get involved. Really important, when I show you some of the results, not everybody answered every question in the survey. And we gave permission to do that, and we built different functions so that people could save and come back, or they could just leave the survey halfway through if they wanted to. So, very quickly, some of the results that we got. So, next slide, please, Ryan. Thank you. You'll remember I talked about the principles that we developed. We wanted to see if people still agreed with them. They did. You'll recall I came to an earlier board meeting to give you some really early feedback. Not much has changed since that first initial feedback. People still are telling us that they like the principles that we've been using for the last few years. So they're really, really very committed to all of them to a high degree. So over 75% approval for all of the principles, and much higher than that for some of them. So basically, people want a health system that's local, it's fair, that's joined up. They don't want to go to hospital unless they really need to, which is good to hear. They want us to invest in treatments that are effective, and they're very, very, very committed to community-based services, and they want help to support them and to maintain their health, which is all good news. They did come up with some other possible principles we might like to consider, which are on the next slide. Thank you. Access, not unsurprisingly, lots and lots of feedback from people, and this is a recurring theme for the rest of the slide presentation. Easy access to services locally. They want to be efficient, and they want to make sure that there's timely access. Comms comes up a lot. Good communications that are clear and are on time, timely. Some feedback about personalisation and wanting us to think of a principle that's to think about people in around, not just a set of sort of conditions sitting in front of us. So thinking about them and their lives and what affects their sort of lifestyle behaviours. A principle around promoting personal responsibility for their health. I know this is one of the constitutional rights, NHS constitutional rights, doesn't often get a lot of attention. Actually, people saying that they think it's important. Equity, support for carers, fantastic. And then something about thinking about people with complex needs, ignoring on long-term condition, very much linked to that earlier principle around personal care. Next slide, please. Thank you. The priorities, again, we asked people here to rank priorities that we previously identified. There's a bit of difference between the People's Panel ranking and the public ranking, not a lot. The top one is still redesigning the way we do things to ensure that the services people need to use regularly are available close to where they live. This might be providing services in a community hospital, local health centre, or people's own homes. People like local access to services. They want us to be funding medicines that have the greatest benefit and targeting services to ensure greater consistency in people's health. So that's great in terms of reducing health policies. They want us to be targeting services to places where we need it the most. Bit of discrepancy, but as you can see, the things that are important to people are making sure that close to home, good quality, things that are effective. They did identify some other priorities. Again, thinking about that local theme, better communication and coordination between the patients and the services. Waiting times does come up. I'm really sorry, those of you who are working in primary care, GP access to GP appointments comes up. Even though we know that we're delivering a lot more GP appointments than we ever had before. Equity, quite a bit about the NHS remaining free and fair for everybody. And then this emphasis around self-care, reducing unnecessary demand, so people getting involved in their own care. Next slide, please. I feel like I'm rushing, but I've got a lot of much to share with you and leave some time for questions. We asked them how can we get this value for the NHS pounds, reducing waste and duplication. Lots of really practical suggestions here. I will make sure I share all of the data that people for whom this is particularly relevant. Streamlining the management, NHS managers often get this kind of feedback. Reducing bureaucracy and red tape, better use of technology. Really conscious that, that this was quite a big part of the conversation at the Health Review Street yesterday about using technology to make us more efficient, etc. Investing in our staff, promoting that patient responsibility again. There was some feedback about introducing charges to NHS services, particularly for non-UK residents, but also sort of a penalty for missing appointments. People thought that might be something we should explore. Comments about procurement, and then two things which we've heard before: integration between NHS social care and then that care post care. I think that was in terms of people not having to travel quite so far, potentially less impact on resources for the wider system in terms of value for money. Next slide. So we're going to focus now in on neighbourhood health in particular, so the N of now. We've done a quick word cloud on the what three words that we ask people to use to describe what's most important to them about neighbourhood health and care. We did ask people to differentiate between themselves, their family and their communities. But I'm just going to show you the what's most important to you slide here, not least because they're very similar, but each of the times that we ask people to do this. As you can see, access, local, coming up as the most important and most frequently occurring things from that feedback. Next slide, please. So this was a really important question that we managed to ask this time around. We wanted to check how people felt about the idea that services and support people use most frequently should be available close to where they live, and that it is a reasonable suggestion for people to travel further for services they don't need as often. As you can see, the results are that yes, you can do agree by and large. So a little bit of difference between the two types of surveys that we completed, but over 75% of everybody who's responded thinks that's a reasonable supposition. There are some reasons why people think that's not reasonable, and now on the next slide. So for some people, travelling further for access to access services is the problem. One's particularly listed are people who aren't very well, they're not feeling great, people with a disability and older people, and people without forcing transport. People mentioned costs associated with managed travel, they mentioned poor public transport, and there's some concerns which are the repeating theme through the feedback about we start to people feeling that if they were having to travel away from their local area to a larger district, so that might provide some potential community setting. So these are some of the reasons why people didn't feel necessarily comfortable with that. Yeah. Next slide, please. We particularly wanted to ask something about children, and you'll be pleased. We looked at obviously the work that the local authority has done around developing strategy for children and young people. We wanted to add in a sort of a question about living a healthy life as possible for all children. And these are the answers that people gave us, the ideas that they came up with. Very much around it being a whole system approach. They wanted us to focus on early education around healthy lifestyles. Lots about food, particular efforts on ultra processed food came up very frequently. They wanted to us to think about focusing on mental health, which I know is something we're already doing, but it came through very loud and clear. Support for parents, tackling poverty, obviously, Siobhan, major impact on health and all things to do with well-being. And then some very specific examples around good community spaces to enable children and young people to get out, play, spend time with their friends, and get some physical activity at the same time. Next slide, please, Rand. So, thinking about seeing a specialist. So this is a question we've asked before as well. And there's not a lot of difference between the two types of surveys in terms of their priority. So very reassuring for specialists. Expertise is the most important thing for people. And then secondly is the time that they have to wait for their appointment. Interestingly, the distance that they have to travel is the least important thing when they want to see a specialist. So that's helpful in terms of some of the direction of travel we've had around creating centre sectors in one place in the county. So this mirrors feedback that we have from people over the last few years as well. Next slide, please. We then wanted to ask people about whether they're needing sort of urgent help for either a physical or mental health concern. Conscious assessment was the most important thing for both of the surveys, and then 7 days a week access. Again, distance to travel is the least important thing in terms of accessing urgent support. So I think that, again, very interesting when we're developing models around the urgent emergency care pathways. Next slide. We're moving into online digital. I think I'm doing okay for time. This is the workout for the family for online digital. Again, the most important thing, and this is coming through loud and clear, I've talked all about it previously, is around security. So there's some important to people that if there's data about them, it's shared safely, security. If they're wanting to access it themselves, they want that to be as easy as possible. Again, the feedback on this particular question for you and the community was very similar to the family. So just going to show you what I can see it. But keeping it secure, really, really a crucial bit of feedback that we got from the population. Next slide. So quite reassuringly, but just I'll give this with a caveat, the people who have responded to our survey obviously are people who potentially are slightly more engaged with health and care services anyway. However, less so with the people's panel because they are randomly selectively sampled. Most people have access to digital devices, and most people feel reasonably comfortable using them. They're using websites and they're using apps. However, this is really important. Almost half of the people who responded say that they really like doing things face to face. So I think I can't remember what the phrase is that Paul uses, but there's something about digital and there's always going to be an offer which is a non-digital offer. That's quite a high percentage of people saying that they preferred to do things face to face. And again, this issue around security and safety potentially being a barrier to people using digital and technology. The top three concerns that people had, the first one being that lack of personal contact, and then security. Next slide, please. Thank you. So we're going to move into well-being, which is the last of the areas. In terms of the things that are most important, good support, good information, and keeping it local and easily accessible. Okay. Next one, please. There. So lots of people were active that were giving us feedback. Lots of people, however, were not aware of what was available in their local community. The ways that people find out about what's going on has moved on over the years. Social media came out top every time. Friends and family, who knows, those friends and family might be getting their information from social media as well. But newsletters, people love a newsletter. I live in a village, that newsletter drops on my door, I love it. I'll check to see what's going on in the village hall. A lot of people are giving that type of feedback. Local radio, local newspapers, I'm really sorry, they came really, really low down on the list of places that people find out about information. And then sort of community centres and shops didn't really come up very high as well. So the fact that we're maintaining a good social media presence is really very positive. And it's just quite a trusted brand as well. Next slide. Okay, so we asked people about things that are already happening in their local community. Lots is going on. I've just listed a few of the things here. Lovely to know that people are getting out, getting fresh air in their communities, etc. However, there are some things that we might want to focus in on. A bit about promotion, letting people know what's happening. Focusing in on things to do with social isolation and loneliness. Nice to see here something about inclusive and intergenerational opportunities. I picked up on some specific groups that people talked about where they were older people and younger people doing things together, learning from each other, and it was mutually beneficial. Very interesting. Support volunteers, older people, and again, there's quite common themes running through all of the feedback that we've received. I think this might be the last slide. We focused on the survey feedback. These are some of the bits of feedback from the engagement events that we held. Only slides here. Very important. A lot of people told us they had fantastic care. Okay, so it's not all about the negatives, not all about things that we can do better. People gave us lots of compliments about the service they were receiving. Local services, key priority. I mentioned before about the disproportionate number of responses received from the public in Cotswolds, particularly Cirencester area. This was specifically because we've got some tests that change at Cirencester Hospital at the moment. Lots of people wanted to talk to us about that. I'm very interested in seeing the outcome of that. We had to do quite a lot of work to explain to people that they were temporary, we were testing things, and it wasn't about a permanent change. We were testing just to see how we could do things different potentially. Interesting at the engagement events that we had with the underserved communities, strong feedback from them that they'd like to have conversations rather than completing surveys, that kind of thing. They'd like to have a discussion, which is very helpful. Obviously, time consuming, but the benefit and value of it was really appreciated. Social isolation came up as a key issue. I wouldn't want people to think it's just about rural. There was a lot of conversation about social isolation within the urban community, and not just with older people as well. We should consider it just to be an issue for older people. Time faced with BCSE colleagues, and then waiting times always comes up. And I'm so sorry, I have got a special slide in about family care, because there were a few comments back about that. Getting an appointment is actually poor. That's one thing about bit confused about how to contact GP practices these days, because there's lots of different ways of doing it. And people are getting a bit confused, and then it's this concern about maybe GP face-to-face appointments going. We did a lot of reassurance to explain, yes, they're great, the digital, etc., but face-to-face appointments will be maintained. And then just the last slide is the next step. So we'll be sharing all of this, obviously, in more detail with colleagues. I'm publishing it on our online participation platform, Get Involved. And finally, just thanks to everybody who took the trouble to share their feedback on this. Thanks for race through. Sorry, Jane. Happy to take any questions.
Thank you, Becky. Yeah, lots in there. So we haven't got a lot of time left. In fact, we haven't got any time left, but we'll do a couple of questions if that's okay. Siobhan?
Quite interesting about how we've been forward. So finding out more screening is interesting. I think from a pure health perspective, there's a process on screening. Most screening will have some negative because of concern or false positives, etc. So it's about how do we make sure that we don't end up inadvertently promoting something like prostate screening, which the National Screening Committee is going to be looking at, for example, and there is something effective checks to roll that out. Because that in itself can cause pressure on GPs when people aren't clear on the messaging. So it's even about what's our role in getting that information out clearly. Early diagnosis is separate but very important. And I think the personal responsibility is another one that's quite an interesting one that we have to be slightly cautious with, because whilst I absolutely agree we need to be supporting people wherever possible to manage their own health, we need to be careful as a system and health professionals that we don't slip into victim blaming people when they don't, because it could be very easy to say, well, you had an offer to do it and you take it, and therefore you didn't take your own responsibility, and that's on you. So it's just again thinking about how we message that as we move forward. And then the bit about what's on, I think it's just worth remembering there are things available like Your Circle, which is an online website that you can use. Like the glitch has gone on. You click on things to do activities and hobbies, it comes to 319 hits across Gloucestershire. So there is definitely stuff there. And again, our group's aware that they can put their information on that. But that's central repository. Are we promoting that enough? So those are just a few things to think about. And I guess the final point would be, it's great to hear what people think. I suppose it's a challenge always of it's a small proportion, 60,000 people, and who haven't heard from, and what we do to ensure that we're capturing the views of groups that might not traditionally respond to these services. But thank you, it's great work and thanks for everyone.
So yeah, the first one, and then
So I'm not sure if I've shown those ones.
It's the right one.
Two things came out of this presentation. One is explanation forms. The slide about people accessing information. It was talking about social media, which is all quite receptive. Were you collecting any information on proactively searching for information, such as going to your circle or looking on NHS 111 to Google searches? And did you cover specifically more, I suppose, adult social care side of things, the Your Circle, the carers hub, those kinds of ways of finding information?
just going to go to the question that we asked, if I can find it quickly so that I don't hold everybody up too much. Which was your next question? While I'm writing, and I'll this at the same time.
My next one is possibly a very low level question for this group. People were asking for specialists who can deal with more than one problem. That looked like it was probably the second or third priority on the charts that you were given. It's a while since I was in clinical practice. What's the current direction of travel regarding priority specialists or old-fashioned general medicine consulting?
So on that one, I think people were talking about people thinking more about the individual as a whole person rather than necessarily the clinician needing to be expected to know everything. Yeah. So I think that was what that emphasis was on. So I will go back and I'll have a look, see how I frame that so that it's clearer. It was more about the kind of collection of things that are of importance to me. They don't necessarily expect that person sitting in front of them, the clinicians, and they're everything about everything, but they want them to be taken into account. So a good for instance would be, my mother is very hard of hearing, but she also has other things, but she wants to make sure that they speak clearly or they can find information on the way to her so that she knows something they're talking to her about when they're talking about her neck, for instance. And I found the list that we gave people for their choices around how they got information. Friends and family, local radio, community centres, village halls, village town newsletter, local newspapers, GP surgeries, local shops, and social media. So we didn't go specific, like Your Circle, for instance, which I know is excellent, and I think we feel quite like
So, Maggie, do you want to answer a specific question about direction of travel, and then I'll go to Douglas and Jack.
Thank you, Chair. Yes, absolutely. As we get into a multi-organ organization, not just practically, but also in the second 5 years. So what we want to do is to build the capability that can have the patient receive as an outcome, using the expertise as they need, rather than attending a new like a better story of not being going to see the patient results. That's the direction of travel, and we need to develop both general practice as well as the generalist physicians in this, and that's clearly our direction.
So I think we take Douglas and Jack's comment on the same time, or not together, but one after each other, and then we've got one after. We could try talking at the same time, but I think it might be a bit.
I'm interested in this slightly different combination of responses around digital. So almost the top of the list, we're receiving information online. Concerns about GP access, whether face-to-face is on, so that's a concern. One of the things noted when talking about how the NHS can be more efficient, digital, but 7 out of 7 in terms of priority. So I think we need to pick through that a bit because that's quite a mixed message in terms of really quite comfortable getting information. I think there's maybe something about it being perceived as a deficit, or it would be, and digital will take something else away. And maybe we need to think about how we're both planning and also communicating about digital helping being supplementary or helping things be more efficient and easier without it always being a replacement. And I think it felt like to me that it's been, as soon as the question's being asked, it's been interpreted as a replacement of rather than a supplement to or a tool that will help things become more efficient.
Just come back on that quickly. We've got some more data, which I think we have time to build in today. We asked people about what they currently use digital for. I think about that, you know, but we also asked people about whether they consider using digital technologies, whether they've already used them, whether they prepare to use them in the future. I think a deeper analysis of that with colleagues, I think will probably be really helpful, because I agree. It's a bit contradictory, so the feedback we get.
Thanks, Becky. Yeah, a lot of hard work into that, and really interesting. That's got a lot of pride. What my question to do with it? So,
I've been in public services over 40 years, got to do lots of public surveys, and they're very interesting, and then they don't form the way we make our decisions. So my question is about how does this get into the evidence chain for us to make decisions about how we apportion services? And then what's the weighting of it compared to wider data, research, clinical and professional opinion, and of course political opinion. So if it's not weighted against them, then you look at it, I think that's really very interesting, but we don't do anything with it. So I don't know whether you can answer that or whether that's the wider one for board members.
It's probably a question for absolutely everyone sitting around the table. Just to let you know, though, it's already gone into some of this has already gone into the 5-year plan. So some of the key messages that come through are already in the interim version of that that's been submitted. There's a new iteration of it, obviously going in later this month or beginning of next, which will have even more of this led into it. So it's got some status within that plan, which is really helpful. In terms of sort of a hierarchy, that's always very difficult to know where something is missing. What I would like to say is that people listen, and we have the opportunity to go back to the communities that we've talked to and tell them how it's made a difference, so they can see where it's fitted in. That's my particular role, is to make sure that people continue to want to be involved, because they can see the difference that it's made. We do publish all of it in public domain. We do put it on something called our Insights Library as well, so that other colleagues can see it really easily and they compare it against any future work they might want to do. And that's also shared with colleagues across the region and nationally as well. But yeah, I think the rest of it is a conversation for the whole board, and actually for all of our partners in the county, not just the city.
Yeah, thanks, Bethany. Just a final point on that. The board meeting last week, for those who were there, I talked about us having to make sure citizens can brave decisions, and that might not be what the whole wider public feel, but we do have to think about how much vulnerable people, how much frail people, and cater accordingly. So that would be quite important how we feed that back. So we might not respond to everything the public say, because we recognise we do have to respond in a different way because of the resources we've got. It's not, but it will be a conversation we have around the whole stage this week. So that was really important.
Just really help you on it. Our concerns to ensure greater consistency Gloucestershire was one of our ideas. So in terms of differences in having these partners, we do everywhere. We've got the green light.
Great. No, we are running really late. So I know Emma wanted to say something quickly. Did you? No, you did ask. So please do speak. But I'm just conscious that we are running late and we do have to finish this meeting on time.
A minute. Just to say, I think everyone sure is good screening. I think really important on that. We know that different visitors request screening. It's not picked up well. We don't really ask them to do something about that. Self-care, again, really important that there's a real big difference between immediate self-care and somebody who expects to access to any sort of digital or anything. So there's a real difference with that. Pushing personalised practice. I was interested in the word cloud. Access is really big. Expertise is smaller, which I found really interesting. That people thought access over expertise was really interesting, but I think that's all I could say about it. And inequalities, I didn't see much about inequalities, which is what we talk about a lot, but doesn't seem to be on the agenda. So, yeah. I think it's really interesting. The more you look at it, the more you actually think.
We try and find this secret bit for you. I just wanted Becky to say thank you for being specific in terms of children and young people. It's really helpful, and it was really great to see the read across to the co-production work we've done around the One Plan, and you will be looking at us, I know, to help deliver and to be able to respond to this. So you said, and this is what we're doing. So to give you an offer in that space, we are already on with developing a play strategy off the back of launching our family hubs. And you know, strategies are sets of words, aren't they? They're nothing unless they're in delivery and they're about culture. But so what the opportunity that offers us in across our communities are things like Tewkesbury, for example, were telling me about the planning requirements and how they are very thin in terms of safe play spaces and outdoor open spaces. But if we have our own strategy that sets a standard and makes an ask, we empower our planners when they are agreeing new builds, housing developments, etc., to say, actually, this is the standard locally, and what we need are safe green spaces, outdoor spaces for children. So it really will translate into visible action. Excellent. Thank you. Thank you. Yeah.
To say that. So thank you very much. And Jeff,
Trying to consider everything you had into that presentation. I think you've got to circulate slides as well for people so that they can, if they want to have a bit more, spend a bit more time just reflecting on that level of detail. It's already embedded into the planning, and we'll continue to do have a big conversation about how we actually do bring some of that evidence and that information to how we look at our strategic commissioning going forward. So thank you very much. Brilliant. So as I said, sorry we are it's worth having that conversation. We are running a bit late, so just as we go through some of the other parts of this agenda, it'd be good if you could try and catch up a little bit. No pressure on you to be quick, but I'm going to hand over to Shane to chief executive.
Thank you, Chair. And a couple of things Becky shared with me yesterday, the actual report. You can get lost in it. So to summarise it like that, thank you, Becky. There's an awful lot in there. But just to come back to Jeff's point, how much percentage energy and thought you put on this is our decision, not anyone else. And therefore the culture of the organisation we're creating, this will be a real test of that organisation, because if this is really important, how does it influence our decision-making process? But Becky, thank you. In terms of, I will make this quick, TDA report is there. 3 big things, which I always do in terms of the board. We reference 3 big things for this board meeting: planning update, learning disability pathway update, and decision on identity procurement. I'm assuming the paper is read, Chair, so I'm not going to go through it in detail for obvious reasons. I'll just highlight a couple of things quickly. In terms of the planning, we've got medium-term planning, which needs to be in middle of February, February 13th, 14th, coming Saturday. And running alongside that, we've got a 5-year strategic plan. As a board, we'll look at that in more detail in closed session. But I think what's important is both BNSSG and Gloucestershire are agreeing a similar framework, which allows us to come together. And the issue at the bottom of page 3 of the report, the big thing we're talking about: healthy lives, health equity, and best value. And that's a common thread going across both plans. So we can start to look at the whole system, not just individual parts. But we will get into much more detail in that. Moving on to learning disability pathway, this got a good hearing yesterday in OSC, we're very aware. A lot of work went into really listening to the voices of people with lived experience and expertise, clinicians, carers, BCSE, etc., to really understand what the future pathway for learning disability clients and patients are. I think it's very clear in my report. We talk about looking at a real community-based, asset-based enabled model, which has an impact on inpatient beds, but we've got to make sure we get the right patient model around that as well. But we absolutely want to make sure the best place for someone to look after and to flourish is in their home. But occasionally there will be times that you need inpatient models. And that's really what that section's about, and a very clear part in the county what we're doing. Now, And then the third element then is about dental, and it is a good story. Real investment in further dental, Smile Together CIC has submitted that, and it is both urgent dental care, but also really trying to build some future resilience into that, becoming a training centre, and really exciting. So it is about stabilisation, of course it is. This is a real footprint to launch from other things that we've done. So happy to take thoughts, comments and questions, Chair. I hope that's helped you catch up with them.
Thanks. Any of you got some questions? No. I'm not trying to stop you from speaking. I don't think I'm particularly scary, so I'm sure you would if you wanted to. But okay. But thank you. And there are some really good stuff in there, and the dental access is just fantastic. So really, and the feedback we've had from the communities around, and lots of different people about that has been really, really positive. So I think it's really good. Okay, so we've got next is the board assurance framework. Tracy.
So, pleased to see that we, as each of our board meetings, have updated our insurance framework, where we currently have 13 strategic risks, 10 which are rated red and 3 are amber. And you'll see that we've made it clear where the kind of commentaries have been updated, as we've made that in red for you to see quite easily. I understand that the board assurance frameworks have been to the relevant committees, but haven't yet been to the audit committee. So we are a little bit out of sync. But these each of the strategic risks have been viewed by the respective committees. There are 2 areas I think just to draw your attention to where we've seen a change in scoring. So that's BAF2, which relates to our strategic risk of how we're taking a community and locality focused approach to delivery of care. And you'll see that we've amended the wording in relation to that risk around the integrated neighbourhood models and our ability to really accelerate the delivery of pathways of care for frailty and dementia. And Jonah may want to comment on the revised scoring on that. You come at this point, Jonah.
Yeah, so we did update this one. I asked the team to look at it, and I think it's just a reflection of the transition process. So, of course, it remains a high priority, but I think it really has to reflect the transition process that we're going through in terms of the delivery of initial care.
And then the second risk where we've amended the scoring as well is in relation to primary care. So again, the strategic risk around the instability and resilience in primary care due to increasing cost and financial risk, where we've amended the score from 15 to 20. And again, you'll see from the narrative that primarily relates to the additional requirements around the new regulation for primary care from October last year, and the pressures that we know that is placing on primary care, particularly around online consultations and greater demand. And then secondly, around the cost pressures that we're seeing for community pharmacies in relation to kind of cost of living. So those are the 2 main variations in terms of scoring, but as you'll see, lots of relevant kind of wording updated for each of the scores. We are obviously looking at this in the context of our clustering arrangements, and the ICB don't use a board assurance framework in the same way that we do. They have an overarching system strategic risk register. So we will be coming back to the board in due course to think about what approach we take into next year about how we describe and manage our collective strategic risks. Happy to take any questions.
Thanks, Tracy. And just a quickie, I know we downgraded this ages ago, and I've asked about it previously, but the risk that the ICB fails to deliver and/or sustain performance improvement in urgent and emergency care is currently at 12. That seems really quite low compared to other current risk scores. And I just wondered whether you've reviewed it recently, whether we think it's quite right.
Yes, we're covering the question online. kind of mitigated position. So I'm happy to go back and ask the team again to check that triangulation is ongoing, but we certainly did this the first time that came up. I would say that, you know, compared with potentially where we were last year, I think, you know, urgent emergency care is in a relatively, I'm going to touch loads of them now, really good position, and that's because of so many of the actions that system partners have taken. Yes, it's still a huge risk, but I think there is lots of work going on to mitigate this risk.
And you think it's right relative to the other risk go down with?
I'll review it. I think it's a fair challenge. Yeah.
I actually wondered whether that too, in its provision, has been made too specific. And becomes more of a program delivery risk than a strategic risk. I think the strategic risk is not making enough progress on neighbourhood health writ large in relation to strategy, rather than necessarily not making specific progress on the financial and frailty proposals. So I just think it might have gone too narrow.
Let's come back on that one. So I think if we can look at this thing, that's actually more committed around that model and around the investment around the model to align, that gives us a bit more support. But I wonder if actually we need to describe the wider context and then have a line in there. So I'm happy to take that away. Thank you.
Great, thank you, both helpful. So I've got Joe. Well, it's two Joe. So Joe 1, Joe 2, and then Kevin.
I was going to ask about part 2. I'm sorry. I was going to ask about part 2 as well. It's just from an impact perspective, are we clear enough about the impact on the system and the cost to the system of that risk increasing potential delays? Because I think there's lots written there about what the risk might be, but I was less clear about the impact. And is that acceptable to the board, or actually do we need to do something else to accelerate the risk again?
Yeah, I think that is a really good point, and one of the conversations that we're having through the neighbourhood portfolio board, and we were just talking about this morning, is actually what impact are you expecting to have through that particular model. And you're absolutely right. If we then articulate that, are we then worried that we're not going to be able to get that delivery? And clearly this is around frailty and non-elected in the first instance in terms of the impact. So again, very consistently describe the impact.
I think that answers the first point of my question. I'm going to be fair to you, Gemma, it's to the board at large. Given the potential impact, are we comfortable accepting that that is the risk of transition, or should we be doing something to mitigate that risk further than being challenged to the board?
I think we can move on to Joe. I think it's covered. So my question was about Factor 13, which is in relation to the transfer of services out of the ICBs and that negatively impacting the deliverability of savings. I just wondered how big is that impact? What's the extent of that impact? And also to what extent does that impact all ICBs rather than
Thank you, Joe. We are at the moment working through particular transitions. So as people
The
were
original talked about all these living this. The most recent initiative is someone. So that's trying to understand how we deal with that and how to deal with that £19 cost. So we are working through with CAP and with the equivalent of BNSSG, working through the design process this week, in the workshop to try
to get an understanding of how much risk we are going to carry in this transition process. I think it's fair to say that I'm comfortable it's a main risk at the moment. It could be high. Okay? And I think that's what we're working through tonight. We have an all-day workshop on the 4th of March, 4th of February, and 11th of February. And at the end of that, we'll have our target operating model nailed down, and we'll be able to be absolutely clear about the risk of the
Thank you, Chair. That relates to risk to that. on infrastructure. I just wonder whether we need to look at the current score for that as well as an increase. Because I think there is a systemic risk there, particularly in relation to the tower, that would impact all organisations around the tower today. Also, the departments of the BBC risk as well about whether we are doing as much as we can in that space in terms of total flow to be able to speed up the decants over parts of the town. And mitigation controls in place at the moment really focus on governance and money as opposed to sort of operational response. And I think that, and I know there is other work happening, we could add to those mitigations, but I think that the degree of risk being carried at the moment would have a significant impact on all organisations around the table. And I think the warrants scoring at 20. And obviously, there's the associated patient safety and harm risk that would play out to them as well.
Thank you. So I think from Kevin's last suggestion, yes, we do know that there are significant risks around the infrastructure and the changes that we need to make on the tower. We will take, I think we can take that away and have another look at it. I think it's important that we do because the impact on the wider system could potentially be very significant. So we need to do that as well as the populations that we serve. I think the point about transition and the risks around transition are well named. We know that that is likely to have a significant impact, and that may in the short term get worse. I think the way we should handle that initially is to take it to the transition committee, where we meet, because that actually covers both BNSSG and Gloucestershire ICBs. I think there are quite a few people that are in this room that actually attend that group. So I think it would be important that we take it there to discuss. And I think Jeff's more
I agree with that. Yeah. I also think, yes, it affects all ICBs, but it affects some more than others. Because if the pound per head population that we spend on the Gloucestershire is significantly more than some other areas, then there's a bigger impact. Now, I know Rachel's online from NHS. It's important that both myself and Shane are talking to the region about what those risks are and then what the likely impact is for us here. And we'll do that. We'll do that in the round, but I think we've got to bring that back to the transition committee and talk it through and think about how we mitigate it as best we possibly can, Shane.
If I may share, it is a requirement from NHSE that we provide an insurance statement after we've done our work about how we as a board are assured that we can meet what we've been asked to do. So we will have to, as a board, via the transition committee, sign off an insurance statement. So we are content with where it's wording about the stamp duty regulatory requirements. We are going to have to insurance statement gets into that. Yeah, those are changes we're making. We believe we can manage what those parts of.
Thanks for your comments. Should we move on to the
Integrated performance report? Obviously, this has contained a lot of detail. We're assuming everything's read papers. But we've got the little trio, little four of you that are just going to do the highlights and answers and questions. So I'm going to Mark.
Thank you, Chair. Yes, we will agree on the national performance standards on the people dimension record quality. Yes, there are more questions before we happy with the finance thing. So just in terms of the national performance standards, the board will be aware this will be going to the plan or that work was part of that work is around bringing our positioning areas where we're currently failing to hit in full national performance standards. The emphasis of the board will be aware is very much on sustainable performance within the system, including through targeted investments from us as commissioners in both NHS, independent sector and out of county capacity to support that position. Colleagues will also be aware that as part of that plan, there's a significant step change in performance against a number of those standards in terms of the targets that we've been set to the system. So we're
well on with working that through for the new financial year. Just a few areas to mention, particularly refer to slide 71 in your pack, the summary slides. And just to say, in terms of, mentioned earlier, didn't we, general practice access, performance continues to be strong. And you'll see from the report that the volume of primary care appointments continues to increase, continues to be above plan. One of the suggestions that our audit chair made when we took this report to the System Resources Committee is to include some additional information showing that trend and indeed the type of appointments taking place in terms of face-to-face, virtual and so on. So you have that within the pack. Good to see the strong performance in terms of vaccination delivery set out, and likewise with cancer performance overall being ahead of the national trajectories. Colleagues will be aware that the system has really strong elective access performance, as again set out within the report. There's also been some additional national funding that's just been announced in the last week, which we're taking advantage of to try and get ahead of the field, particularly before the end of the current financial year. And then finally, in terms of urgent emergency care, Gemma's already outlined the more stable position in the system, albeit with challenges, but good to report the ambulance handover time improvement, so a significant reduction in ambulance handover time, with the lowest average ambulance handover performance in the southwest during that pressured month of December. So enormous praise needs to go to those teams who are delivering that on the ground. Just finally from me, a couple of areas of focus. So diagnostics remains a pressure point. Colleagues are aware of the challenges, particularly in terms of high numbers of long waits for endoscopies. So additional capacity has come on stream within Gloucestershire hospitals. That is starting to impact. And of course, as part of the plan for next year, we are in discussion around a more sustainable solution to bring down those endoscopy waits, and indeed a business cases and the developments within the trust to assist with that. I referenced cancer performance, still pressure in terms of the breast cancer pathway. The pressure with urgent emergency care, as I mentioned, is still there. So we're very much seeing that in terms of numbers of 12-hour reaches in the emergency departments. And that is a situation, sadly, that is happening across the country, that continues to be a real focus. That's it from me, and Stacey, thank you.
You set that out in the report for GP and some system-based work we did in our workforce. Again, particularly to draw your attention to the fact that we are a widening access demonstrator site, and our requirement was that by the end of this financial year, we would have supported 100 young people into positive destinations in terms of educational placements, work, experience, or volunteering. You'll see that we're well on track to meet the expectations set out there. You'll see as part of that, we've been doing some work with the King's Trust, which I think I've previously highlighted. And we've had enormous interest in the RCN cadet programme. We have done a cadet programme for some time. We started one a couple of weeks ago, and we've had like 100% attendance. So, Jane, I think your heart sing, just in terms of the level of interest in that. Colleagues will see and be aware. Obviously, we had the opening of the city centre campus on the 15th of September with the Princess Royal, and as part of that, she did come to visit the new Arts, Health and Wellbeing Centre. We just set out again in the report some of the development offers that are currently underway in that centre, and some of our achievements so far. We did agree at the last People Committee that we will invite some of our partner colleagues for a tour of that facility, so we can make the best use of that space, and particularly the immersive suite, which has got some unused potential at the moment. So yeah, that's what I wanted to say. Thank you.
I just want to say I love the immersive suite. It's so good. There's so many things you can do.
Thank you, Chair, and I'm standing in partly for my colleague Marie, who's not here, so credit to them for leading that volunteer agenda. And so some headlines that potentially maintain the multi-party data development on the study of 9 months like it used to stay. Also credit to colleagues who take the care of this program care to code rights to mix. I want to highlight the no only project which was just again the story here and Mark touched on the vaccination. Areas of focus coming to be aware that we are concerned about the impact of physical health and mental health. So these are the deep dives to get that limits that they we're looking at outcomes and see how we can improve their care. BCG colleagues will be aware that we had a problem with recent vaccination uptake, and we have a plan now to catch up and improve on that. Maternity, we are is doing the continuation work with police to improve the services. There's a lot of improvements have happened since we started this journey a couple of years ago. With their needs, the health assessments, and is taking. Other issue that I wanted to highlight primary care platforms onboarding for that. So we're pleased with that. It actually works despite the normal strain that general practice is under. I'm happy to take any questions.
Thank you. So before we move to finance, so if you've got any questions for either Mark, Tracy or Matthew.
I was just going to ask whether any really too about CDC activity and whether there was a to try and just it's very good showing. Nice to me. So I said.
Yes, so our community diagnostic centre, yes, and we have been looking at that. So we're looking at part of the plan for the media. And indeed, we've had a regional visit in the last couple of weeks. We think there are some further opportunities in terms of using that facility. You're absolutely right; it's a fantastic facility. The feedback from patients is excellent. There are some issues, of course, in terms of being that capacity on stream in terms of some of those particular something we've sort of that are improvement challenges. But yeah, that's very much part of the plan. Absolutely, that's easy.
Okay, so can we move to
So in terms of the financial position, the central cost related system and for each organisation within that. As you'll recognise, we've had significant pressures in GHT. There's been a huge amount of work across the system, and particularly obviously GHT have brought down quite a number of their costs through that work. They're also implementing the peer review recommendations, and so that's bringing the benefit to them. In terms of other areas, we have also received some additional funding for industrial action within GHT for November and December. That's also helped the financial position. So we think we can continue to forecast break even as a system and for each organisation within. In terms of capital, we continue to forecast break even for each of the providers within the system. You'll hopefully remember that we had a contingency that's been held within the ICB. We have implemented some plans to utilise the majority of that contingency now through different routes, community equipment being one of them, primary care being one of that providers. We're not able to utilise that within the year. They've utilised some, very much really about there's a smaller spend which is now forecast against the contingency of about £1 million. The number 2 agreements, G, who are able to use that cash. Just to note that in terms of cash, so GHC cash is in it's a broadly on the plan. GHT's cash is slightly off the plan. Some of the mitigating actions I've described, some of the allocations coming in support help to do that. Their cash position is almost slightly less helpful than GHC's. that's where the actually come in with internal planning really does come into play. It's, don't get that right, the cash position will not improve within the system. Go to payment code. So both providers are kind of improving and within 90% upwards position, which is very positive. I'm afraid I can't report the ICB position as of ledger and issues. But we are behind within the ICB. We want to bring that to number 6. We are behind. Unfortunately, we can't tell you where we are currently, but we are catching up on ourselves, but not yet able to onboard. So that's fine. Thank you, Ken. Any questions?
It's just a comment really around the question of independent sector providers, which has come up again and again and again. And I suppose it's really just to say, I do think moving into the new commissioning world, there needs to be some thought given to how to get better levers to deal with the independent sector providers in terms of being able to manage the demand from them. So it's just a comment really.
Thank you. Thanks, everybody. Okay, shall we move on to the sort of next, or the main, one of the substantial items, which is an update on what we're doing with the health and quality assurance. I think that is Douglas. Emma. Sorry, Mark.
So I'm going to just kick off with a little bit of a reminder for those people who were on the board about a year or so ago. We started with a sense of trying to look at health and quality slightly differently, because we felt that in the system here tended to become a scheme-based thought process. Let's have lots of schemes, and we were missing some of the broader aspects. So we developed this broad framework to try and make sure that we were challenging ourselves to have activities and to have focus across all 3 of those domains, recognising some of the broader contributory activities were contributing to health and policies, even if we hadn't badged it as that. Yes, there was a place to target attention, and we need to be quite good at targeting those, but also we need to work ever harder on increasing the equity of our mainstream service offer, rather than seeing that everything about health and quality was a targeted scheme. So that was the sort of thought process, and we then from that did a bit of an exercise, which we were quite clear at the time wasn't meant to be a sort of mapping exercise. It was meant to be a sort of where are the commitments we're making across this framework. I think some of our reflection was it probably ended up being a bit of a mapping exercise despite less efforts. But if I move on, what has happened since is some of the work in the system around that framework. Also, there's been an NHS Confederation Building Policies framework, which is similar but slightly different from the Gloucestershire approach, but there's quite a lot of overlap there as well. So it's something about us kind of centering around how do we kind of adapt and adjust to make sure that our overarching framework is as understood as possible. And then if I move on to the third slide, these are some of the things that came back from an October 2024 exercise against that. What are the partnerships with Gloucestershire and organisation doing in relation to those 3 needs? And you see some of the examples of specific activities or commitments against it. So essentially, perhaps trying to broaden engagement and also broaden that sense of commitment to doing more against each of those 3 themes. I did say, though, however, some of the reflection was, did it still come a little bit like a mapping exercise about collecting what everyone's doing rather than actually getting to the point of making more commitments to do more? And that's what's led to a little bit of a change of approach, which Siobhan's doing through. So I'll hand over to Siobhan.
Thank you. So yeah, next slide.
So working each of the organisations across the system and colleagues from the integrated work partnerships came together in a health and quality champions network to have a look at the framework and think about what might be more useful moving forward. So it used the original framework and developed a revised template, also using the NHS England one nationally. And it's kind of a light touch, essentially, maturity matrix with 5 key ambitions. So it's really focused it down rather than trying to do everything on that original framework. The Health and Quality Champions thought that these 5 things were the most important to look at. They are navigable. I don't think they're navigable in the PDF document, but certainly if we send you the original slides, you can have a look at those documents themselves. And it's a tool for each of them for reflection and supportive conversations in the organisation about practice and progress against each of those ambitions. It helps them to generate plan for improvement on each. It's very self-reflected, it's not directed. However, we can then, because we've asked about what outcomes you're using to measure your progress within it, we can then collect the outcomes from the whole system. It's much more focused on what we're actually delivering. The template shared with the champions from each of the organisations and the integrated work partnerships in December. And there's been a conversation about what a realistic timescale for getting that back, and then how we're going to pull together the output, and equally each champion make sure that their strategic leaders in their organisation knows how they self-assess with colleagues in their organisation moving forward. And then Mark's going to talk about next steps.
Thanks, Siobhan. So, and Siobhan and Douglas have said this is very much action focused. It's very easy, isn't it, for public sector organisations to observe health inequalities, measure health inequalities, but it's much more challenging to actually do something about them. So that's the board is aware, and the board has been champion this framework, something that would really encourage action. So we're in the process between to the end of February to gather information from each of the health inequalities champions within each of the partner organisations. We've then the process obviously of reviewing all of that information, and as Douglas said, we do the test really in terms of, is this business as usual, is there a stretch within what each organisation is committed to, and it's really good to see obviously chief exec colleagues, director colleagues doing some of that challenge within our organisations. I'm very much doing this within GHFT, with you also Bob as well, Deborah and Douglas, and colleagues within Gloucestershire Health and Care, and that has had an impact. That's chief exec sponsorship, and indeed Siobhan's sponsorship as well of this as the other SRO. Then we're going to bring that back to the board in March with a summary of that and where we think that's got to, and then we're bringing all those health inequalities champions back together in the spring. We found that really has been a benefit, bringing those colleagues together. This is not an easy job leading this work within an organisation who have so many competing priorities. So that's as much as anything about those colleagues supporting each other as well as working within the framework. And then coming back to the board again in May. Douglas mentioned the need to align this with the national framework. I know you were involved with the national framework. It's really important that we do that and that continues to develop. Of course, we also need to align this with the work, some of the work that's taking place within the other parts of the cluster. Thank you.
Thanks very much, the three of you. Has anybody got any
Questions? Yeah, Aisha and then Jane.
Okay, thank you. Just a couple of comments. Really,
Microphone. Sorry, being bossy.
Okay. Really looking for this is competition for the beauty library, and really good to see the development of this. So there's 2 comments. Firstly, it's really interesting when we talk about looking at outcomes across the system, because we've got a bit of an organisational focus then at the moment, what organisations doing, and actually we probably need to marry that up with how do populations experience this. So groups of people who may, hearing earlier about people having to tell their story multiple times or having volunteered different appointments with different parts of the system. So you're not going to be able to build that picture if you're looking at organisational
kind of outcomes and action plans. And then my second point is probably a bit in contradiction of that, which is about primary care. So Mark, you mentioned organisations, action plans, and you mentioned all the organisations, and then you've got primary care, and I was wondering to what extent, and then my to what extent are we asking these questions and looking at what the service responses in primary care? We've got the GP club here, so is that something we need to bring on board with this, because it isn't just about the acute community trust accepting the ICB. It has to be about primary care, given what we've heard earlier today about access to appointments, people feeling that they're not getting the access. And our last PCDC conversation about appointment access was, actually, do we know who's getting the increased appointments? We know there are increased appointments in primary care. Are the people who are the most vulnerable, who actually need the increased appointments more, getting those appointments? Do we know that? So is that where that kind of feeling of I can't get a GP appointment is coming from, because it's people perhaps have those multiple long-term pushable, are from deprived backgrounds, can't access appointments, even though we are providing more. So
thank you, really helpful questions, and we want to make sure we pick up the primary care piece. And I think one of the first things we did when we looked at the framework was remember that the aims of the ICB is to improve access and experience as well as outcomes. So access and experience are equally important. A lot of the targeted work does tend to focus on outcomes as opposed to those other two aspects. And that's where that column on the right about the mainstream service is really important. And again, we kind of looked at the language, is that right? But what we mean is, any service that we operate, are we looking at the inequalities that are inherent within that, in the standard day-to-day? And then you might do something that is then targeted to address that. But because we weren't routinely doing that within services, we weren't necessarily systematically picking that up. The question about who's filling out the template and primary care, we were very careful to not make this a must-do from the top down. And we kept it to the major organisations around the board where there might be multiple different things going on, and the integrated locality partnerships. So primary care would be picked by that, as would the VCS. And some of the VCS were saying, well, can we fill it in? We were like, yes, but we're not going to ask for a report back, because that might create an expectation, particularly on VCS organisations that are very small. And I think similarly, GP practices might not have the capacity to do that. So it's a very long answer to say we haven't systematically asked for it, but very happy to explore conversations about how the tool might be used in primary care, and that might be something we keep up them in the collaborative now that it's established.
You've actually nearly answered the question that they asked, which is, this is brilliant, and it's a brilliant way to start looking at the community of what we do and moving forward. I suppose my point was, we also in the cluster commissioned £4 billion of service. How do we know that £4 billion of service is actually having a major impact on health and quality, as opposed to maybe a project-based approach? And therefore, this is brilliant. But actually, everything we do, we have to ask the question: what impact is it having? And it's not having the effects that it's having. Got a question: why are we doing it? So as long as that's also part of the wider conversation, I think it's a really great thing. But the biggest impact we're going to have on health and quality is spending the money, current spending, wisely, as opposed to let's look at these things.
Yeah, I really appreciate what you've done. I have to say, when I saw that, it's really disappointing. I couldn't see primary care anyway. And there is a huge amount, as you know, in terms of language translation. And there is specific work going on. And there's all extra resources into health and quality areas, isn't it, primary care. And so it would be really nice to have that interest and that recognition of what we're doing. Because when you look through that page, everybody has something to say. And we look like we're just, once again, not on the page, which is just, I'm sorry to be negative about that. And the collaborative is a way to make this, to improve this, to make this better. But again, we have resources, very limited resources, and we need to look at have things like that going forward, because we will, you know, there is huge amounts going on that we can share with you.
So just on that point, was that from an exercise that started in the May, June time, probably predated collaborative, which is one reason, but also children point out that we're very, very sensitive to this becoming a task that people have to do, and getting really get a little bit of that, or even having to fill something in, and so it's just trying to make sure we're doing with the energy. So I agree, there's loads of energy in this, and we need to find better ways of expressing that, and recognising clubs is has not go to the doors from that, but it might just be a coordinating mechanism for trying to get some of that energy. The point I was going to make a change point is that point is exactly where we started from in terms of that third bucket, as I call it, in terms of which I do think tends to get lost. And actually, realistically, what we recognise in that sometimes you have to go in through a data and understanding place first before you get into how we sensitising ourselves to mainstream delivery. But Alicia's comment about access, do we even know, is the first question, do we even understand? And what I say to clinicians in particular is, who are you dealing with that's been referred to you? Who should you be seeing that hasn't been referred to you? And asking those questions is the way you start getting into the mainstream offer, being sensitised to your population needs. So it's just trying to drive that to sort of improvement focus rather than a scheme focus.
We are now almost time. I've got 4 minutes and Becky has to speak again. Perfect. Becky, last comment.
The presentation at the beginning was all population, all demographic, all in one. What we can do is we can have, so what we can do is we can have a look to see where people were coming from. We make comments about access to GP equipment. So I can check my postcode and look, see whether it's 420 or if it's up across the county. We can run that report really. Is that the only breakdown? Do we have ethnicity? Yes. Yes, we have age, ethnicity, the whole gamut.
Excellent. Thank you very much. Really great to see this work. That piece of work is so important. The next items we've got on the agenda are info information. So these are verbal and approved minutes of the various different committees. What I'm going on the basis we've got 3 minutes left. What I plan to do is just ask chairs to say anything that is absolutely vital that needs to be said at this board meeting, on the basis that we will have minutes that will come back in March too. So on the basis that I'm first on the list, you have already had an update on the committee that was held in October from Julie at the last meeting. So I'll take the minutes as read and assume if you've got any queries, you will raise them. And from the meeting we had in December, pretty much everything that's in it has either been covered already by updates or we are discussing later. We did have an early look at maternity needs assessment, and we had an excellent update on children's continuing care improvement plan. And other than that, I won't say anything more. So I'll move over to Julie who will load it.
Thank you, Chair. You can see the report from the board on the 11th of December. I don't have anything to add to that, but I would like your attention to the red assurance at the bottom, which is related to risk arising due to the implementation of the Oracle ISAP 2, which is sort of referenced by Kath by saying we're unable to report on certain things at the moment. I think it's known, it affects all ICBs nationally, and NHS is aware of it, it's very high on their risk register. There are a number of mitigations around that have been put in place by extra checks and balances and controls that are being operated by the finance team. And I think really what I want to say is it can't be underestimated the extra workload associated with not only putting in a new system from the 1st of October, but having to put extra controls and balances and processes around a system that is still being developed. So that explains some of the issues around reporting, which is causing quite a lot of extra work. But I am reassured by the finance team and by conversations that those issues are being resolved as we go through. And that everything is being mitigated by extra effort from the planning team. So I just wanted to know my thoughts. Thank you, Julie. Thank you for supervising the team, and just appreciate this additional work on top of what was already very exciting and very transition. So please, Aisha.
You've got minutes, in terms of C1, finding care, as you might imagine, we had quite a long discussion about the backlist score, which was we recommended getting increased, which has been. Backlist scores gone up and down a lot. I think it went down because there was as usual, there's been a really concerted effort by the primary care team to build those relationships with primary care. It is coming back up as a risk because of the contractual changes. And despite the hard work of the team, it's just really difficult to mitigate that. And we had quite a long discussion about that. So it was a very carefully considered recommendation around escalating that risk. And that is the only thing I think about. Thank you.
Joe. Joe.
On which the which of our meeting in January was focused on the medium term plan, which will be business. So I think that's
And Karen.
Yeah, our most recent meeting was last week. Lots of it focused on the people stats that are included in your pack. And the second half of the meeting was focused on handover, and in particular how key things like the decommissioning of the wellbeing line, matters like Oliver McGowan training and others, governance roles and responsibilities would transition between organisations. And finally, it was our last people committee before we moved to our new format. So we extended thanks to all of the team that have supported the people committee for their collaborative and open working over the last 2 years.
Thank you, Karen. And as we recall, I also extended our thanks to you for chairing since you arrived. And I think it's probably worth saying, as this is the last public board that you will be at, because you are moving to the end for, I can say it, GHC. So GHC have gained an extremely good and fantastic net. Very, very sorry to see you go. But I just wanted to say thank you on behalf of Gloucestershire for everything you've done to integrate people. So thank you very much.
Thank you.
Okay, have you got any other business that we wanted to raise?
No? Okay, well, in that case, under the provision, section 1, section 2, the public bodies of